The widespread use of antidepressants, particularly selective serotonin reuptake inhibitors, SSRIs, like Prozac, Zoloft, and Paxil, represents one of the most concerning intersections of pharmaceutical marketing, medical overreach, and public vulnerability. These drugs, initially introduced with the promise of revolutionizing mental health care, quickly evolved into blockbuster products. But beneath the surface of glowing ads and ubiquitous prescriptions lies a more troubling story: that their effectiveness, especially in cases of mild to moderate depression, has been consistently overstated, while their risks and limitations have been undercommunicated to patients and even many prescribers. Antidepressants became widely available in the 1980s and 1990s during a period of aggressive direct-to-consumer advertising and mass cultural destigmatization of mental illness, both positive developments in some ways. But these efforts were coupled with an industry-led simplification of complex neurobiology into a convenient but misleading narrative. Depression is caused by a chemical imbalance, specifically a lack of serotonin, and SSRIs correct this. This theory, now widely discredited among neuroscientists and psychiatrists, was never conclusively proven and grossly oversimplified the reality of mood disorders. Still, it became the foundation of drug marketing and public understanding for decades. What emerged was a system in which SSRIs were prescribed not just to patients with major depressive disorder, for whom the drugs may have moderate benefit, but to millions with situational sadness, grief, or mild depression, conditions that often respond better to therapy, social support, or lifestyle interventions. Multiple meta-analyses, including landmark work published in the British Medical Journal and The Lancet Psychiatry, have shown that the difference between antidepressants and placebo in cases of mild or moderate depression is minimal to non-existent. In fact, for many patients, up to 80% of the benefit can be attributed to the placebo effect, especially in trials where participants are aware they are being medicated. Yet this hasn't slowed the proliferation of these drugs. At the height of their popularity, SSRIs were prescribed to tens of millions of people in the United States alone. Drugs like Prozac and Zoloft became household names and generated tens of billions in profit for their manufacturers. Off-label uses expanded the market further. SSRIs were prescribed for anxiety, premenstrual syndrome, personality disorders, and even chronic pain. This overreach has serious implications. First, it pathologizes normal emotional responses to life events. Sadness, grief, and disconnection, unpleasant but natural parts of the human experience, are increasingly medicalized and medicated. Second, it obscures the importance of addressing root causes: trauma, social isolation, poverty, poor diet, sleep deprivation, and more. When pills are presented as the first or only line of defense, systemic and behavioral solutions are neglected. There are also real physical and psychological risks. SSRIs can cause sexual dysfunction, emotional blunting, weight gain, insomnia, and, in some cases, suicidal ideation, especially in younger users. Moreover, discontinuation symptoms can be severe, resembling withdrawal and making it difficult for some patients to stop using the drugs even when they want to. These issues are often minimized or ignored in the initial prescription conversation as clinicians, under time pressure and lacking mental health infrastructure, reach for the quickest available solution. Perhaps most damaging of all is the erosion of patient agency. The narrative that depression is purely biochemical leads people to believe they are broken, chemically deficient, and permanently in need of pharmacological correction. It can be profoundly disempowering to hear that your sadness is a disease rather than a message, one that might be pointing to something real and changeable in your environment or inner life. None of this is to say that antidepressants have no value. For severe, treatment-resistant depression, or when properly managed as part of a broader therapeutic plan, they can be life-saving. But the problem is scale and misapplication. When a drug developed for the few becomes prescribed to the many, driven by profit, convenience, and oversimplified science, what we're left with is not mental health care, but a medicated society that increasingly confuses chemical suppression with healing. The story of antidepressant overprescription is not a conspiracy in the traditional sense, but it is a consequence of powerful structural forces: pharmaceutical marketing, diagnostic inflation, underfunded mental health services, and a culture desperate for quick fixes. It's not that these drugs never work, it's that the story we were told about how and when they work was polished, packaged, and sold to fit a business model, not a medical reality. And in that distortion, too many people have been left not truly helped, but merely subdued and profitable.